So I guess firstly, thanks to ANZIX for allowing me to present my research, which has a very long title, and for those of you who know me, that probably doesn't surprise that many people. But in a nutshell, I've looked at risk of clinical deterioration and clinical review criteria, or track and trigger, or whatever sort of between the flags, whatever sort of phrase you want to use for it. Firstly, thank you to the study hospital, which was Epworth Richmond, Deakin Uni, and my research supervisors. So, I'm going to present on background, study aims and methods, phase 1 and 2 results, study limitations, conclusions, and then recommendations for future research and clinical implications. Now, I'm very sorry that this is pre-lunch, and I perhaps should have made my slides a little more interactive and fun, but anyway. So I guess for many patients, death occurs in hospital. We know that survival post in and out of hospital cardiac arrest is poor, and we also know that all hospital patients are at risk at some stage in their clinical journey of acute clinical deterioration. So this has seen a paradigm shift that we're all here talking about. We are at a safety and quality conference towards recognising and responding to clinical deterioration, which was Standard 9 and is now Standard 8, and the introduction of the MET and clinical review criteria. I know I'm preaching to the converted, but obviously the MET and CRC are both sort of clinical indicators of acute clinical deterioration that should elicit some response. The cost of clinical deterioration is significant, but obviously we don't know what the figure on preventable deaths is, and that's a very hard thing for us to look at, but we do know that ED patients and patients admitted via ED are at significantly higher risk of acute clinical deterioration. So the study aims were done in 2 parts. Largely it was a retrospective observational study. So the phase 1 study was to compare the prevalence and time to MET activation between patients admitted via the ED and those admitted electively within 24 hours of admission. 24 hours was chosen, I guess, following some background research to look at sort of what other studies have shown in terms of risk of deterioration for ED patients. And firstly, we needed to figure out if there was actually a problem. Because yes, all researchers have their hypotheses, but we need to figure out if it's actually worthwhile reviewing further. Phase 2 was to compare the prevalence of CRC prior to MET activation between the same cohorts. So the other thing that made things slightly challenging with our study and our study hospital is that our ED has a slightly different clinical review criteria than that in use on the wards. So particularly if you look at the respiratory rate of greater than 20, systolic blood pressure of greater than 150, and a heart rate of greater than 100. Now I know Karen spoke in her sepsis about a respiratory rate of 22 being significant with sepsis, but I'll talk a little bit more about the sort of limitations of having a different criteria as we go along. The fact that sort of, I guess, ED patients are undiagnosed, unknown, often more unstable, is the sort of presumed rationale for the difference in clinical review criteria. This is our track and trigger chart. The purple highlights the MET, the yellow highlights the clinical review. MET criteria is standardised across the organisation. However, you will notice that particularly for those of you who are used to working in a public environment, there are additional MET criteria that include things like urine output and blood tests in our MET criteria. So, as I said, we did it in 2 phases. So phase 1 looked at 2016 administrative data just using the sort of admission computer systems for the calendar year. The riskman data, so it's local hospital policy that all Met calls and code blues are entered into the riskman incident report computer system, and that's where we retrieved that data. So of our 52,601 elective admissions, there were 1,007 Met events. In the ED cohort, there were a little over 9,000 admissions with a little over 556 Met events. Now, Met findings were indicative of Met events rather than the number of patients experiencing a Met call, and that was so that we could track how many had them within the first 24 hours, but also how many patients had subsequent Met activations within that same admission. All Mets were sort of date and time stamped to make sure that we were removing duplicate entries and to make sure that we had a reliable database to start with. Phase 2 involved a manual medical record audit of 100 randomly selected patients using the IBM SPSS software. Initially, we chose sort of 50 ED and 50 elective patients, and that data was collected on an Excel spreadsheet, which looked at reason for Met activation, but also clinical review criteria achievement in the sort of hours preceding Met event. The other thing of note is where patients achieved Met, sort of more than one Met within that 24-hour time frame, we only collected it up to the first Met. So, there were a little over 1,500 Met activations, making overall hospital Met prevalence 2.52, which is a little different to Julie's presentation and that sort of thing, but it is also a private hospital. A third of all Met activations occurred within 24 hours. Almost 90% of those patients achieved a vital sign call-in criteria, and almost 11% achieved the nurse worried criterion. ED Met prevalence was actually 3 times more likely than elective. That was when you compared the number of ED Mets to the number of ED admissions, so that we're comparing apples with apples and so forth. This table basically shows of the 1/3 of patients who achieved Met within 24 hours, broken down into elective and the ED cohorts. Median age was 68.8 years, relatively even gender split between female and male. What is interesting, and probably less ideal for my desired study outcome, but that's okay, is the median time to Met activation between the two groups within that 24-hour period. So the ED patients actually had a later Met call by about 5 hours than the elective cohort. However, the other thing that I found particularly interesting is the length of stay, which is overall hospital length of stay, increases when ED patients have Met calls within 24 hours, and that increased by 2 days, which is obviously has financial hospital implications. In terms of the admitting unit, given the types of patients that Epworth Richmond see, it is, I'm sure, not surprising to anyone that most of the elective patients come in under surgical institutes, and most of the ED patients come under the sort of medical institutes. So phase two results showed that hypotension was the most prevalent Met activator regardless of type of admission. Removing the hypotension, following that for the ED cohort, there was 26% of nurse worried or clinical concern patients and 22% of Met activations for uncontrolled pain. You will also notice that there is, in the ED clinical review criteria, there is a pain criterion, but there's not once patients go up to the ward. In the elective cohort, second to hypotension was hypertensive MET activations. Then we drilled it down a little bit more and we looked at if patients achieved any clinical review criteria prior to their MET activation, and found that across both cohorts, quite a significant amount of patients achieved clinical review criteria, and that hypotension was the most prevalent CRC MET across the board. What we didn't do though was look at if that was acted on and therefore resolved prior to MET activation. So the limitations of our study: single site, private hospital, questions its generalisability to bigger tertiary centres, and the types of patient cohorts that come through the door both via ED and electively. We didn't adjust for the number of MET calls compared to admissions in each cohort. So given, you know, the 9,000 ED admissions versus the 52,000 elective admissions, perhaps we should have chosen more elective admissions to review. CRC and MET are not standardised across Australia, which makes it really difficult, because a lot of what we know about clinical review and MET criteria is actually anecdotal evidence when you go back and track sort of observations and changes in observations before more subsequent deterioration. But given they're not standardised, it's difficult to draw clinical recommendation, hard and fast clinical recommendations of, sort of this number equals deterioration. Was 24 hours the most appropriate time frame? In retrospect, probably not. I know there's been some studies done, particularly in things like orthopaedic surgery, that show that hypotension in the first 24 hours is quite significant. So maybe for ED patients, I should have pushed it out to 48 hours. But in terms of conclusions and recommendations, other than the fact that it helped me successfully complete my master's, what we do know is that ED patients are more at risk. How we fix that and whether we can implement preemptive strategies to fix that is sort of, I guess, subsequent sort of information and things that we need to look at. Hypotensive CRC is of concern. So getting back to Julie's, let's give them a fluid bolus and get them to the ward safely within our 4 hours. And full disclosure, I'm an ED nurse as well. So, think twice about the patient that has had a fluid bolus and their number fixed, because chances are they'll end up having a MET call once they get to the ward, and usually that'll be in early admission. The utility of using the ED CRC to predict subsequent deterioration may be low because the criteria are too narrow. So if we remove Karen's point about sepsis and a respiratory rate above 20, for those of you who are medical staff, if we're reporting every single systolic blood pressure that hits 155, you and the nursing staff who are routinely seeing these numbers are less likely to act upon it as you should be. But conversely, maybe it does elicit a faster medical review and means that we're implementing care at an earlier stage in an unstable ED patient. Pain may be undertreated at the ED ward interface. So bearing in mind that 22% of our ED cohort had MET calls for uncontrolled pain. By default, elective patients who are often having surgery and being sort of having their pain treated by anaesthetists perhaps means that ED are less good at managing people's pain, and I'm sure the anaesthetists love hearing that, but that's okay. Further research is warranted into the reasons of the use of the nurse worried criterion. So I did look at it just because I had such a small cohort, and it was more sort of clinical syndromes than hard and fast numbers. So things like allergic reactions,
Rigor's increasing heart rate but not meeting MET criteria was enough for the nursing staff to actually elicit a MET review. And I guess keep encouraging nurses to do that, because there's lots of research saying that their gut feeling is enough. Any questions?